Atrial Septal Endocarditis Complicating Tricuspid Valve Endocarditis. So I have objective to recognize the atrial septal endocarditis in patient without any atrial septal defect or patent foramen ovale or any device closure for PFO as well. Role of transesophageal echocardiogram in the diagnosis of infective endocarditis and atrial septal endocarditis, and role of the medication in the management. So I have 26-year-old male with medical history of Hep C, tricuspid valve endocarditis, and IV drug abuse. He had a tricuspid valve Staph aureus endocarditis 4 months ago, which was treated with prolonged course of antibiotic. He had a TTE at that time that showed 1 centimeter tricuspid valve vegetation and moderate tricuspid regurgitation. And there was no involvement of atrial septum or any congenital atrial septal defect at that time on the TTE. So he admitted with complaint of progressive shortness of breath and non-productive cough that has been going on from last 2 weeks, associated with pleuritic chest pain, fever, weight loss, and decreased oral intake. Patient reported recent IV drug abuse 2 months ago. He denied any hemoptysis, night sweats, any incarceration, recent travel, tuberculosis exposure, or history of positive PPD or HIV. His exam, he was hypertensive, blood pressure 95/53, tachycardic 102, respiration at 18. He do have decreased breath sounds at lung basis. His labs was significant for AST and elevated mild transaminitis with alkaline phosphorus 356 and total bilirubin of 1.5. He do have mild lactic acidosis, which trend down to 1.6. And the WBC counts for 114,000. So he had an X-ray and a chest CT. You guys can see that on the X-ray there were multiple foci bilateral, and same also on CT scan as well. So they read that it could be consolidation, it could be septic emboli or metastatic disease, or maybe it could be vasculitis, granulomatosis with polyangiitis. And the same findings were found on the CT scan as well. So he was thought to have either recurrence of endocarditis or maybe persistent of previous endocarditis, which he had a few months back. He was starting on IV fluids and antibiotics. He had another TTE that showed mild right ventricular enlargement, and there was decrease in the size of tricuspid vegetation from 1 centimeter previously to 0.67 into 0.9. Probably that vegetation has spread to the lungs as a metastatic septic emboli as well. So he was scheduled for TEE to evaluate for either persistent or complicated case of endocarditis. TEE showed equidense mass on the atrial septum, most likely endocarditis, and there was 1 centimeter flap on the top of that mass that moved back and forth in the right atrium. And there was also small tricuspid vegetation as well. So this is a TEE that showed the mass attached to the atrial septum and the 1 centimeter mass on the top of that as well. So he had positive polymicrobial blood cultures, E. faecalis, and then Streptococcus H. parainfluenza. He was continued on antibiotics because we don't have any clear-cut guidelines on the management of atrial septal endocarditis in patients who do not have any AST or PFO. We do have on the rest of the endocarditis more than 1 centimeter if we have fungal vegetation, if there is perivalvular abscess, but in that case, there was a complex making decision regarding the further management approach. We consulted cardiothoracic surgeon for any recommendations. They said continue the conservative management with antibiotics with plan to repeat TE in 1 month. The patient stayed in the hospital, had another TE that shows some decrease in the size of vegetation from the previous one, and he responded well to that. Because we talked to the family and they were concerned about that vegetation, so they want some other opinion from another tertiary center. So we talked to Vanderbilt, and they recommended same conservative management with plan to repeat TE after discharge in 1 month. So he had a third TEE that showed almost complete resolution of the vegetation, and there was some mild tricuspid valve vegetation. So I do have videos of each TE in the sequence. So this is the first one. So you guys can see this vegetation is moving back and forth in the right atrium, and this is the atrial septal vegetation as well. And that's for the second one. So there is some decrease in the size of vegetation with antibiotics as well. And that's for the third one, which he had 1 month after discharge from the hospital. So almost complete resolution of the vegetation. So what is atrial septal endocarditis? It can happen as an isolated event or with AST or PFO as well. It has been reported following percutaneous closure of PFO device with PFO and AST as well. It's very uncommon to see atrial septal involvement without any congenital defect as well. And there were only a couple of cases reported with that AST. and some of them called Septal lesion or maybe alien in the heart as well. They called different names. It's very rare and some unrecognized complication of tricuspid endocarditis, and there was only one case of complicated with mitral valve endocarditis as well. So it's an interesting case of endocarditis complicating tricuspid valve and with septic emboli to the lungs as well, diagnosed by two criteria. So it has been reported in literature associated with the mitral valve endocarditis. Not every patient with tricuspid endocarditis complicated with atrial septal involvement, but it is important to consider TE to rule out any other concomitant structural valve abnormalities and atrial septum as well. There are different factors that can involve in determining the progression of vegetation from the tricuspid valve to atrial septum. That include the size of the vegetation, degree of the regurgitation, volume and velocity of regurgitation, and host response to infection, and the wildness of the microorganism as well. And the pulmonary involvement is very common with the right-sided endocarditis. It has been reported in 10 to 15% of cases, mostly with IV drug abuse. Like in our case, he was IV drug abuser. And some cases have been reported with non-IV drug, like in hemodialysis patient. So the take-home point to consider TE, to closely examine the cardiac walls and other structure to rule out any concomitant vegetation with the tricuspid valve or mitral valve endocarditis. Because our patient, he had a TEE first, and they didn't see any vegetation. They said that was normal. And might be we could have caught that earlier and treated with medication as well. And the second is that most of the right-sided endocarditis treated medically, but they recommended that if the patient has PFO or atrial septal defect, you should consider surgery because there are high chances of going to the left atrium, maybe to the septic emboli to the brain as well. But our patient was lucky because he didn't have any atrial septal defect or pediform overall. So we considered medical management in his case. Thank you.
That's a great case. I was just curious, did you do any provocative tests for PFO? Because you may not just be able to see it with color Doppler. You may have to give bubbles or...
I think they did a bubble study that was negative. There was no any bubble.
And no aneurysmal change to the septum, right?
Yeah, yeah.
No septal aneurysm.
Yeah. Because...
That's an interesting case, and of course, the underlying sad part of this is you got a young fellow with substance abuse disorder and comes in with a polymicrobial event at age 26.
Yeah.
Tough. It sets a stage for a lifelong misery for him, even if he's able to shake his disorder. And in terms of surgical indications here,
I was looking for that. I couldn't find anything regarding that.
And can you give us a sense of what the surgical indications would be?
So you can, just like any other case, you can either remove the valve with a patch to prevent the vegetation to be formed, but the hard is to be form a vegetation of the patch as well. But I couldn't find any clear-cut guidelines regarding surgical management. But as I said, that most of the cases have been treated with medications for the right side endocarditis, and he was lucky that he had on the right side as well.
His question was indication for the surgery. So you already mentioned that one is PFO, and if there is a PFO associated PFO or ASD, and if you have an atrial septal endocarditis, then it's an indication for surgery because there's a high risk of stroke.
Mm-hmm.
Yes, with
Stroke
PFO.
erosion, abscess formation,
Yeah.
those sorts of things.
Yes.
Any other questions from the audience?
How long he was on the virus?
Previously, he was on 6 weeks, and then continue on that on discharge for 6 weeks as well, and follow with IDS and outpatient as well.
Thank you.
Thank you.
Our next speaker is Dr. Velagapudi. He's talking about an 80-year-old man with chest pain.